In this video, we will discuss the therapeutic drug monitoring, or what's called also as medicine levels blood test, or the therapeutic drug levels. Therapeutic drug monitoring is testing the amount or the concentration of certain medicine in the patient's blood to make sure that this medicine is both safe and effective. The level of certain types of medicine measured if it's hard to figure out if a dose that provided to the patient is enough to treat the condition or effective, and it will not cause dangerous side effects, and it's considered as a safe level. So it's help the healthcare provider to make sure that the patient is taking the right dose. When the therapeutic drug monitoring are useful, firstly, when there is no clinical marker for the drug effect, or when there poor correlation between the dose and the clinical effect, or when there's a good correlation between the plasma drug concentration and the clinical effect, or for the drug that have a narrow concentration or narrow therapeutic window or narrow interval between the therapeutic and the toxic effect. There are many types of medicine that we can measure the therapeutic drug levels for them, such as the antibiotic, for example, the vancomycin, heart drug like digoxin, anti-seizure drugs like phenytoin, drugs that treat the autoimmune disease like cyclosporine, tacrolimus, and the drugs that treat bipolar disorders such as valproic acid or lithium. Now, regarding to each drug, you have to know if I have to measure the peak or the trough concentration when I have to take the test or the sample, and the normal level for the test, and why I should do the therapeutic drug monitoring for this drug. So, for the vancomycin, we also measure the trough serum vancomycin concentration to make sure that the drug is effective and safe, because the vancomycin may lead to nephrotoxicity. We take the trough concentration for vancomycin after reach the steady state. It takes approximately 4 doses of vancomycin to reach it. The trough concentration should be drawn 30 minutes before the fourth dose. But the trough concentration should be drawn earlier in critically ill patients or patients with unstable renal function. The target trough concentration based on the type of infection. For uncomplicated infections such as soft skin tissue infection, the target trough concentration is between 10 and 15 microgram per ml. But for complicated infections such as pneumonia and meningitis, the target trough concentration is between 15 and 20 microgram per ml. Now, for phenytoin, as we know, the phenytoin has narrow therapeutic index, so we should do the therapeutic drug monitoring to make sure that the phenytoin level is both safe and effective. So, for the first concentration, we have two choices. First of all, we should consider obtaining the sample within 2 to 3 days of therapy, or if the patient's given give IV loading dose, the sample should be drawn after 2 hours after the IV loading dose. Or if the patient's given oral loading dose, the sample should be drawn within 6 to 12 hours after the oral loading dose. And this helps us to determine the maintenance dose, or if we need to reload. The second concentration, drawn within 5 to 8 days after the initiation of therapy. then the phenytoin will be adjusted accordingly. Patients who are using long-term phenytoin, then we should monitor the levels at 3 to 12 months interval. The amnoglycoside antibiotics must be given parenterally, since they have poor oral bioavailability and they are excreted through the kidneys. The plasma half-life is 2 to 3 hours, except when renal function is impaired, but the drug may accumulate in tissue. If the therapy is continued for longer than a week, tissue sites become saturated and plasma concentration may rise. So, we do the therapeutic drug monitoring for amnoglycosides since if amnoglycoside plasma concentration are above the necessary for bactericidal activity, that will lead to reversible nephrotoxicity and irreversible ototoxicity. Now, the therapeutic drug monitoring related to the amikacin is essential to achieve the effective dose and avoiding the toxicity, especially for infants, elderly, and obese patients. Uh, the target concentration is for the peak concentration 20 to 40 milligram per liter, and for the trough concentration is less than 8 milligram per liter. And the timing of the peak concentration is drawn 30 minutes after completion of 30 minutes infusion, or in another word, uh, after 1 hour of the initiation of the infusion. While the trough concentration or the trough sample concentration drawn within 30 minutes prior to the next dose. For extended interval or once daily dosing, we obtain a random amikacin level between 6 and 40 hours after start of the amikacin infusion. As we know, digoxin has a long half-life from 20 to 60 hours, and it's usually given once daily. Patients with kidney disease or reduced glomerular filtration rate may suffer from toxicity, so we need a dose adjustment for digoxin in those patients, since the digoxin clearance is primary by the kidneys. Blood samples should be taken at least 6 hours post-dose to allow time for distribution to tissues. For patients with heart failure, the effective plasma concentration um, between zero point 0.5 to zero point 0.9 microgram per liter, and if digoxin is used as antiarrhythmic, the effective plasma concentration between 0.8 to 2 microgram per liter. This table shows the drug and the therapeutic range for each drug.